discussing today's topics from an African American perspective. This is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham Lee. Hope you're enjoying this beautiful, beautiful Friday afternoon. The weather's great out there, so thank you for joining us. On Another View on Health, we care about all of your health. That means your physical health, your mental health, your financial health. And so I have two things I want to bring to your attention before we talk about our main topic today, which is colorectal cancer. But I want to tell you that there are two events going on that you may be interested in. First, the 50th anniversary of Medicare and Medicaid is this year, and there are two events that are happening in our area. Wednesday, July the 25th, from 5 until 7 p.m. at the Grandy Village Learning Center. Celebrate Healthcare is presenting an event there at 2971 Kimball Loop in Norfolk. They're having a special guest, Joanne Grossi. She's the Regional Director of the U.S. Department of Health and Human Services. She's been a guest here on Another View, and they're going to have a panel discussion, coverage to care panel discussion, and there you'll get updates on Medicare and Medicaid, and also information on the 2016 Medicare and Affordable Care Act enrollment updates. And then they're going to move the same event to the Peninsula on Thursday, July 30th from noon until 2 p.m., and that's at the Hampton Senior Center at 3501 Kecoughtan Road in Hampton. It's free and open to everyone, so if you want more information, call 287-0277 or go to celebratehealthcare.net. And those of you who may be looking for a job, heads up, Kroger is holding a huge job fair tomorrow. They're hiring for all of their Hampton Roads area stores. So that's both the South Side and the Peninsula. Tomorrow from 9 a.m. to 5 p.m. And the job fair is being held at the Kroger Training Center, 2029 Lynn Haven Parkway in Virginia Beach. That's in the Salem Crossing Shopping Center. Now, they have all kinds of positions that are available. Go to jobs.kroger.com if you're looking for a job in this area. Kroger wants to hear from you, so go check it out and see what's going on. So there was a new study published this month in Cancer Epidemiology, Biomarkers, and Prevention, which is a journal of the American Association for Cancer Research. And in the study, researchers identified 3 geographic hotspot areas where death rates from colon cancer are unnecessarily high. The lower Mississippi Delta has the highest rates, 40% higher than the rest of the country, followed by Western Central Appalachia with 18%, and Eastern Virginia, Northeastern North Carolina with 9%. Yes, that includes Hampton Roads. So what's going on in our area, and how can we get our numbers down? Joining our discussion today is Dr. Scott Cross, oncologist with Virginia Oncology Associates. How you doing, Dr. Cross?
Doing well.
Great. Thank you so much for having us. Reverend Evelyn Lee, Associate Minister of Congregational Care at First Baptist Church, Butte Street. Reverend Lee, welcome.
Thank you.
Thank you so much for joining us. Reverend Gloria Newsom, Associate Pastor for Evangelism and Missionary Outreach, also at First Baptist Butte Street.
Hello.
Welcome to the show. Thank
you.
And, of course, my co-host for Another View on Health, cardiologist Dr. Keith Newby. How you doing?
I'm doing well, and yourself?
Good. I'm doing great.
All
so
right.
you got your church family here, don't you?
Yeah. I'm a low man on a totem pole in the church in the church family, but I needed somebody smarter than I here with us today. So I think we're looking good.
Well, I was really surprised at first when I heard about the study that Hampton Roads was one of the hot spots. But then I started telling people about the fact that we were going to talk about colorectal cancer today, and the reaction I got, bar none, was, ugh, I don't want to hear about that. I don't want to talk about that. One of the issues is that in our area, people are not getting tested. What's up with that, Dr. Cross?
I think there's certainly a lot of obstacles to getting screened, most of which are just on a personal basis. I don't know I can speak for other people, but I think the most important part you can do for trying to educate people about screening is to actually talk about the colonoscopy itself, because a lot of other things, people are fearful of something just because they don't have enough information about it.
Mm-hmm. Well, they were saying that in the study, that in those three areas that I talked about, Appalachia, the lower Mississippi Delta, and the Hampton Roads, northeastern North Carolina area, that underlying factors, high poverty, unemployment, obesity rates, back to that obesity, Keith, low education and high and health literacy levels, poor access to health care, and lower cancer screening rates all seem to play a role in that. So the community work that you all are doing at First Baptist Butte Street, I assume that, Reverend Newsom, that was a factor in why the church got involved.
Yes, that was a factor in why the church got involved, and we also got involved because we received the grant from American Cancer Society. We received one for breast cancer our first year, and the second and third year, which is this year, we received for colon cancer grant. And we found that people in the community as well as in the church are unaware of the benefits of getting a colon cancer check, screening, a colonoscopy. And we found out that awareness, education is good to help people to understand that they need to take care of themselves and they need to be proactive regarding their health.
Keith, isn't a colon screening a part of the regular checkup?
Well, it's supposed to be. There's a couple of obstacles that I'm finding. One is just the people's interest, because they have a different perspective of where you're going for the colonoscopy. So you got to get past that part first. But secondly, to be honest with you, there are some political obstacles too. Insurance carriers, depending on your insurance plan you have, and we run into this issue where now of course I'm gonna stay politically correct today, but one of the insurance carriers that has a big Medicare population in the area, they only have one gastroenterologist they work with, and so when you think about if you have 1,000 people that need to get screened and you have only one person doing them, that's going to limit the ability to get it done in a timely fashion, and that is, and that's where the unfortunate political aspects come in, because they're trying to cut costs, they're trying to maximize their profits, so they end up saying, okay, well, I'm going to work with this guy, can we get it done cheaper here? But then again, the problem is that the patients aren't getting them done because of backlog. Mm-hmm. So I'm looking at multifactorial why this is not getting done, but that is a big area here. Then that issue of them just not the concept of what you're going to do is scary to a lot of people. And again, most of the guys that do them, they do them so often and so many. I mean, they could probably do it with their eyes closed, but the bottom line is people have that fear factor of the unknown. What is it going to show? And people have this interesting viewpoint here in this area that if out of sight, out of mind. If I don't know about it, it therefore would never exist.
Well, I found 10 myths about colon cancer, and I want to ask you, Scott, to help us bust some of these myths about this disease. So the first one is that colon cancer is a white man's disease. That's not true.
That is not true. Cancer kind of knows no boundaries, certainly knows no ethnicities. I don't think there's anything that would...
As a matter of fact, some of the stats here, that colon cancer in particular affects men and women equally and affects all races. They said that in 2010, there were 102,900 new cases of colon cancer, 53,430 of which were in women, according to the American Cancer Society, 49,000 in men, and 52,000 Americans will die from the disease. And the number one risk factor is age. Is that why you're not told really to start screening for it until you're in your 50s? Is that right?
That is correct. So there's certainly, with each decade of life, particularly after the age of 40, there's an increased incidence. Unfortunately, we are seeing, compared to, say, data from the 1980s or earlier, there's an increased incidence of colon cancer in people in their 20s and 30s. And so there's undoubtedly other environmental factors. This is not just genetic increase. There are, take a step back, there are subtypes of colon cancer that are clearly associated with genetic abnormalities. but those alone don't account for the increased risk that we see in younger people.
So what causes colon cancer?
So that's a very good question. The short answer is eventually there is a single cell that acquires injury or some type of mutation, and that cell, its growth is not regulated. So it may start out as something that's relatively, I wouldn't say benign, but not necessarily truly cancer or malignant, and that's where the idea of colon polyps needing to be addressed come from. So a colon polyp is an abnormal growth, just like a mole that somebody has on their skin is an abnormal growth. Those growths are sometimes referred to as tumors, but the word tumor is not always interchangeable with cancer. It's just an area of abnormal growth. We know that certain types of colon polyps are more inclined to evolve or have a malignant transformation and turn into colon cancer and eventually invasive colon cancer. And it's not as straightforward as there's a orderly progression that you go from an area of maybe inflammatory change along the lining of the colon to a polyp, to a premalignant lesion, to something that's invasive. But for a large number of people, that is the progression that occurs. And to answer your original question about why we start screening at 50 is that time frame from when there's first something that maybe is abnormal at the mucosal surface to the time that it turns into a polyp, to the time that it may turn into invasive cancer, is often a very long lag time, 5 to 10 years. Mm-hmm. And so it's part of the reason why we make recommendations to only screen once every 10 years in people who don't have frequent or obvious polyps. And in general, we don't see that there's a significant impact on overall survival from older data until you start screening at 50, which is why most guideline societies say, for people who don't have affected relatives or some other history of polyps in their family, that they should start screening at 50.
Okay, I want to ask this question. I want to try to be as delicate as I can. Because, we're talking about an area of the body that is not pleasant always to talk about. But some people may think then because you said there is a cell that goes rogue, so to speak, because it is in a part of the body that gets rid of the waste from the body. Is that something that may cause that cell to go rogue?
You meaning
the waste
or something?
Yeah, what's going through the colon, in other words.
So yes. I think undoubtedly we estimate that somewhere between 30 to 50% of all colon cancers are due to lifestyle factors, for which diet plays a significant role. More recently, over the last 3 to 5 years, we're learning an increasing amount of what's kind of broadly referred to as the microbiome, or the type of bacteria that exists in the colon. And there's mounting evidence that actually suggests that those subtypes of bacteria may have an impact on the role of colon cancer. Mm-hmm. Not to take too much a tangent, but I think if you look at the actual county by county data on the study that you cited initially, to me the more alarming thing about it is not that there's a small increase we see in our area, but if you look all along the Ohio and Mississippi River Valley, there's a significant impact. And to me, probably the story behind that article should be, why is there? Because I would not say that either ethnicity or even socioeconomic status along that setting would completely explain for it, because there's plenty of other areas in the country that suffer the same lower socioeconomic status, but it's just very striking that occurs along what's clearly just the Ohio River Valley and Mississippi River Delta and Valley.
When I was reading the comments along that study too, someone did point out that the water, where those counties are that are affected, and that there's water involved there.
And I only bring that up just because, again, when you're talking about different types of exposures that we may all have in common that may increase the risk for not just colorectal cancer development, but colorectal cancer death, that's where we're learning more and more that potentially this idea of the microbiome or some type of bacteria that may actually increase someone's risk for colon cancer, that is something that is worrisome, because that's not something you inherit or maybe have any real control over how you acquire. And we're still in infancy in learning in terms of how to screen for that or how to detect it.
440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. What questions do you have about colonoscopies, about colorectal cancer. We don't do diagnoses on the show, but we can answer general questions that you have. And also, we're going to be talking about how the community can get involved in terms of screenings and in terms of helping us to live healthier lifestyles. 440-2665 or 1-800-940-2240. Okay, so another go ahead, Keith.
I was going to say, because I know people are going to want to know the answer to this question. Dr. Cross, what is the age-appropriate time? Because there are going to be certain people that are going to say 50, but there's certain people less than that. If for the general person, if they say, okay, when should I start getting screened? What would the answer be in terms of what, would it be, in terms of family history or other things, if they have certain disease processes or whatever else, if they could identify, okay, I need to get seen earlier, because they're going to hear the term, the age 50, and that's going to be the majority of what people hear. But realizing there are people that are going to need earlier. What are the things that they need to know that say, okay, yes, I need to get screened earlier?
So really 50 is the gold standard for the average risk patient. So average risk person. So if people have, for example, certainly a first-degree relative that's been affected, then they should be screened at an earlier age. We typically recommend 10 years. Screening begin 10 years prior to the age of that person developing diagnosis of colon cancer. So say somebody was diagnosed at age 52, they missed their 50-year-old screening colonoscopy, and they got diagnosed at 52. Well, ideally you want to tell their children, or certainly their relatives, first-degree relatives, that they should be screened beginning at 42. And again, it goes back to that idea there's a long lag time between when you may see something that's a pre-malignant lesion that you could fix with colonoscopy, remove with colonoscopy, and when somebody actually develops invasive disease. The caveat to that is if you have a family history of colon polyps, and it's just not any kind of colon polyps, but so-called adenomatous polyps, so regular adenomatous polyps or tubulovillous adenomatous polyps, those are the type of colon polyps that we think are more likely to develop into colon cancer, and that's different than kind of a flat polyp or hyperplastic polyp. So if you have a family history of that, then in a similar fashion, you'd want to, that person's children or first-degree relatives should probably be screened a little bit earlier, just to try to catch them before they turn into bigger problems.
And if your primary care doctor does not recommend can you just go to a enterologist? Thank you.
So that
can you just go on your own?
It varies by insurance.
Yeah.
And so some insurers will not require the people that are covered by them to have a prior authorization or referral. Most would require referral.
Reverend Lee,
I wanted to say something about the.
Can you pull your mic up closer to your mouth? Yeah, so we can hear you.
The disparities. We received information during a church presentation by an oncologist who is a member of our church, and he mentioned that for African Americans, the screening should be done at 45. And so I'm wondering if insurance will cover it for persons who just want a screening regardless of family history. And so that really sparked interest. And I know the American Cancer Society's standard is 50. But it worries me, bothers me, that if there are such disparities and 45 should really be the time for us, what can we do about that?
Yeah. And that may be in terms of, as we look at insurance, and goes back to your political point.
Right.
Yes, the only thing I would say to that is certainly if you have somebody who's in a high-risk demographic, and there's other issues we look at that may affect that, so not just the family history of colon cancer, colon polyps, but people who have diabetes are at slightly higher risk of having colon cancer than those who don't have diabetes. And so if you have someone who has multiple risk factors, then that, you take that into account when you look at that person and try to counsel them about when they should start screening. I think the difficult part is some of the data that really implies when we start screening are all data that from surveillance studies that were done kind of in the mid to late 80s that we then follow people over time, and they've drawn a line in the sand, and 50 is that line right now.
Let's go to Raphael. Is that correct, in Chesapeake?
Yes, that's correct. Thank you for taking my call. My call would say that I have been diagnosed with ulcerative colitis since 1980, and I'm in remission, and the way I've been maintaining it is, prayer, of course, but vegetables and fruits, no greasy foods, little meat, and using turmeric, like a curry powder, both in my food and with water. And I'm calling to see what the panel thinks about complementary medical techniques to keep people under remission and to help them maintain colitis and all.
Okay, Raphael, thank you so much for the call.
I think the first thing I would ask Scott this to answer that question. In your this historical data, say from the 1920s, was there like any particular year where there was also this jump in incidence of colon cancer, or was it pretty much been the same? We just diagnose it better now.
So there has been a consistent increase up until kind of the late 60s to mid 70s, and then the peak shortly after kind of 70s to early 80s. Some of that increase was just simply because once we started doing screening flexible sigmoidoscopies, you did pick up incident cancers at an earlier time than when somebody would have been symptomatic and presented with it. But I would say that overall the incidence and certainly the survival trends have improved consistently since kind of late 70s, early 80s. And there's a variety of reasons, why that is. That screening is a key point, but there's a whole variety of other issues that probably play into that.
I bring that up to say that, and again, this is more speculative, I think, than anything else, but I have come convinced as I see our lifestyle, meaning the types of foods we eat, the processed way we get them now comparative to 60, 70 years ago or better, where we had, you think about how they're genetically changing food, how they grow it, how we process it. I mean, I tell people all the time, I get a lot of patients come in, they got the suitcase of vitamins they take, and I just look at it and say, you may not necessarily need to do all that. Maybe you just need to start growing your own vegetables and, kind of just looking at eating less processed foods because, again, we don't really know what we're getting these days. And that's not to say that for everybody to say, oh, man, that newbie said, don't eat this. Don't. I'm just more or less saying that, unfortunately, so because of how they're genetically changing things, how they're pesticides, also they spray on vegetables, because everything is about profit, now, very little about our actual well-being. Everybody say maximize profits, get all this out. So I'm kind of seeing, and my wife and I were talking about this the other day, about when you look at how the foods come out, how we're acquiring them, we just don't know. So I think instead of necessarily taking 8 million vitamins a day, it may just be better just kind of really re-looking at fiber content, because that's the kind of lifestyle I've adopted more, just saying, get away from the processed stuff and just start focusing on what we should be doing, which is eating a more natural type diet, less of the processed foods, and that may be all we really need to do.
If you're just joining us, we're talking about prevention and treatment of colorectal cancer with Dr. Scott Cross of Virginia Oncology Associates, Reverend Evelyn Lee and Reverend Gloria Newsom, both with First Baptist Church, Butte Street, and my co-host of Another View on Health, cardiologist Dr. Keith Newby. Okay, I want to get one thing out so that we can get past it. Let's talk about the test. Because I think that is one of the major things that stops people from getting tested. I've had 2 colonoscopies in my lifetime so far. So tell us about what happens pre-test, during the test, post-test.
So I would say that the test itself is actually the easy part.
Exactly.
And it's the part
I would
that
agree with you.
Most people are terrified of the idea of having, you're going to do what, where. But the real part, when you actually talk to people after they've gone through the colonoscopy, they'll say, oh, the colonoscopy was no big deal. I woke up, I was a little groggy, I went home, I had some gas, a little bit of cramping, but there was no big deal. That was the easy part. It's the bowel prep that's the difficult part. And unfortunately, for many people, especially those who may need to be screened, because they may have diverticular disease or other problems with their colon, they can actually have more difficulty with their prep. And it's incomplete preps cause people to require more frequent colonoscopies, and people may talk to other people who say, well, I had to go back and get another colonoscopy done, 6 months later or whatever. That's a pretty rare situation. Colonoscopies are, not to get into the minutiae of the numbers, but they are very effective. In oncology, we have a limited number of screening tests that are quite as effective as colonoscopies.
So that is the most effective?
It is the most effective screening test for colon cancer, without a doubt. While there are a number of other alternatives, colonoscopy is the only test that you can actually treat the problem at the same time you diagnose the problem for pre-malignant polyps. And so the bowel prep is a hurdle, but it is a hurdle that's easily, that you can get over. And certainly talking to their gastroenterologist or the person who's going to help them with a colonoscopy, that's the best interaction they could have to make that bowel prep more tolerable and less onerous. One thing we didn't talk about earlier, we were talking about coverage, that it sometimes sees a stumbling block for people is that it's often a 2-day process because we don't have colonoscopies on Saturdays. So people have to take at least a half day off work or sometimes more to do the bowel prep, and then they can't work the following day. And I hear from a lot of people, well, if I got vacation time, I'm not going to do that to go colonoscopy. But to me, the thing would be do it once. If you've got no polyps, then you're probably just somebody needs once every 10 years. And so that's a small intervention for your overall health.
Ann joins us from Virginia Beach. Hi, Ann. You're on the air.
Hi. Thank you for taking my call.
Sure.
I'm sorry to ask you this during lunch hour, but what are the symptoms of colon cancer?
That's a great question, Ann. I was going to get to that.
So most of the time, they're very protean or not something you necessarily think has got to be from colon cancer. Some people will have fatigue because of the anemia. Many people these days are identified on screening studies because they were sent to see the gastroenterologist because they had some evidence of iron deficiency. Although the majority of people who have colon cancer won't necessarily have profound iron deficiency as present. Pain, abdominal pain that can't be explained by some of their symptoms is a cause, but not the most common cause. Unfortunately, the majority of people who have colon cancer simply because there's a lot of room for things to grow before they either cause the bowel to not function well or to obstruct. Most colon cancers are relatively asymptomatic until they're more advanced, which is all the more reason why we need to do screening to try to minimize the chances of people being diagnosed with late-stage disease.
Okay, so fatigue.
Evidence of anemia, change in bowel habits, certainly change the appearance of the stool, the color, the diameter, bowel frequency changes. These are all things that kind of buzzwords or things we ask people about. And they're important to ask and discuss, but the truth is most people who have colon cancer, in retrospect, they'll say, well, maybe I had some change, felt a little bit different. But a lot of people don't have any symptoms.
Okay. Thank you so much, Ann, for calling.
And not to cut across, but just to answer Raphael's question, because I think it is important. So for people who have inflammatory bowel disease, we didn't talk about all the different subpopulations where there's increased risk, but certainly people who have inflammatory bowel disease, especially ulcerative colitis, like he described, those people are at increased risk for developing colon cancer. And the estimates are that for each decade of life that they have had inflammatory bowel disease, their risk of developing colon cancer increases by about 15 to 20%. So it's a sizable increase. That the best data that is available for prevention in that setting are for people to eat a primarily kind of whole food, plant-based diet, as Keith was indicating. And there has been studies, especially there's a couple studies in the last couple of years out of Hopkins where they've looked at people who have an inherited form of colon cancer where they have literally hundreds of polyps, and they gave these people turmeric, as Raphael described, and the number of polyps that were decreased were substantial, more than a 30% reduction in the number of polyps. And so there's a variety of what we consider kind of chemoprevention strategies that can involve things such as routine aspirin use. So for people who have a family history of colon cancer, aspirin at doses that exceed 600 milligrams a day are important. Following your vitamin D, getting in plenty of green leafy vegetables because they're rich in methylfolate. And as we're learning, certainly turmeric is a reasonable thing to take to try to supplement it to prevent, and there's good data behind that now.
Okay. 440-2665 or 1-800-940-2240. We're talking about colorectal cancer and the ways that you can prevent this disease. Reverend Lee, let's talk about what's going on at First Baptist Church, Butte Street. Why, first of all, did the church decide, beyond the fact that you got the grant to do this, why was it important to reach out to your congregation in terms of developing a health program?
We believe in helping our congregation and the community in a holistic approach. emotional, of course, spiritually, economically. So our church has a long history of being involved in the community, social action, education. Our pastor is very progressive and supportive, and so we were so blessed and pleased to be asked, really, to participate in this grant. A lot of it had to do with Pastor Gloria's community outreach and her involvement, also being a cancer survivor, and her association with the American Cancer Society. So we were approached and asked whether or not we wanted to participate in this grant. So our first grant was breast cancer prevention, and then the last two, as Gloria mentioned, have been in colon cancer.
Mm-hmm.
And
so what specifically have you done with the colon cancer?
Well, okay, first of all, we're a partner. We're part of the Partnering for Life faith-based cancer outreach and education program funded by the American Cancer Society. Mm-hmm. And so for a year, we are asked to come up with different activities that promote education and awareness. So some of the things that we've done, we focus on trying to change eating habits, because we know in the African American church we love to eat fried chicken and we just love to eat, period. And so we have encouraged our church members to change our eating habits. Mm-hmm. Baked chicken, or always, like if we have a program at church, we try to offer healthy options in addition to. So
I was curious about this. So if you have an event at the church, you will serve baked chicken and fried chicken? Is that what you've done?
We try to, yes.
Okay.
We had a big function for, I think it was Easter. And the spread did have baked chicken also fried. I mean, because we're not talking about an immediate lifestyle change. But I'm proud to say that I do see changes.
Okay. Your congregation will go off on you if you don't have some.
Yeah, right.
So you can't just change people overnight.
Right.
Go ahead, Reverend Newsom.
And also, we implemented exercise. We talked about the importance of exercise, because exercise helps you with your emotions and your mental and stress. And so we let the people know that for a healthy diet, you need to exercise as well. So we have implemented exercise. We do it on Thursdays from 6 to 7. And we have lots of people come in from the church, but also people come in from the community. And we've had an opportunity to exercise congregational on Sunday mornings.
So I saw that in the notes you sent me. So actually in service
that's
on
exciting.
Sundays.
Yes. And our pastor agreed that quarterly we will have congregational exercise. So our next one is in August, the end of August. And it's awesome to see the entire congregation, old, young, pastor, everybody exercising. We also, during our leadership meetings that we have on a monthly basis, we have exercise before we meet. And so that's been great.
What about encouraging men, particularly in terms of getting colonoscopies and checking their health?
Our men's ministry has been awesome in terms of supporting the grant, and they have a yearly health education breakfast for the men. And so last year, Dr. Fleming and Dr. Newby were speakers, and again this year, I know we're going to have Dr. Fleming and probably Dr. Newby again, but the men, and I believe about 75 men came to that breakfast, and so we're real proud of what the men are trying to do and being supportive. And the men actually, my husband and another deacon lead the exercise on Thursday, and we do line dancing. We know that's very popular. We have a woman from another church actually who comes and assists us in the line dancing.
Dr. Newby, when you work with the men in the men's ministry, what are they telling you about, why they may be hesitant to take the steps that they need to take?
Well, it's all about that fear factor that I mentioned earlier. Fear of the unknown is always a scary thing. I tell people, even in, a lot of people will come up with this idea, where, church and faith should get you through, which is true. It's just people are still human. They still have human emotions, human feelings. And sometimes, it's easier to put off your stuff to deal with other people's stuff. In other words, like if we'll see, I have a ton of wives that come in with their husbands in the office, and they talk about, they're all on their husband's stuff. And then I ask them, well, what are you doing? Well, I got to make sure he's straight, and they forget themselves. And so it's very easy to do that, and we all do that just because of that basic fear factors. Part of it is just that education, but a lot of it I'm finding is the fear of the unknown, of what it means to find you have cancer. You hear that C word, that scares a lot of people. I mean, one thing I would give Reverend Newsom a lot of credit for, I've seen, her faith is a testament to see how it can impact on you, because she'll say, and she openly will talk about it, but says it in a way of encouragement to other people. And when you can take yourself out of yourself and say, I'm going to help you because I know what I went through, therefore this is going to help somebody else. I'm not worried about me right now. I'm going to be fine. I want to get you straight. I mean, you cannot, what can you say to something like that? So you can't have anything but the utmost respect for anybody that takes that.
Exactly. Our phone lines are lit up, so let's go to the phones. Heather calls us from Norfolk. Hi, Heather. You're on the air.
Hi, Barbara. I am just so excited about this health-based church experience, and I commend these pastors for leading their congregations. My biggest change that I've done with my diet is adding a lot of fiber, and just to back up what everybody's saying, oatmeal as heavy cut as possible, and a lot of raw cabbage and slaw, and baked beans, and making sure that my processed foods are very limited so I don't get backed up, and bowel regularity is really key. And I did have my colonoscopy when I turned 50, and it was no fun. That prep is really no fun. And like they said, it is well worth getting the information and then starting and just saying, I'm going to get more fiber. I've always done turmeric and curry, but I'm telling you, the fiber, I just feel good about it. And this is a blessing, and I'm glad you're approaching it. Thank you very much, Barbara.
Thank you so much for the call, Heather. We really appreciate that. Let's go to Frida in Virginia Beach. Hi, Frida. You're on the air.
Everyone, I just wanted to call in and commend Reverend Lee and Reverend Gloria for the work that they're doing in the church, and also that there are resources out there for people who don't have insurance for tests other than the colonoscopy, which is the FIT test, which is taken yearly, which will detect blood in the stool and done in the privacy of your own home. But at American Cancer Society, we're so grateful for all the work that's being done in the Hampton Roads area, especially with that recent study that came out. First Baptist Butte Street is doing remarkable, life-changing actually events. So I just wanted to call and commend them on that.
And that's Frida Bryan, who is a breast cancer thriver and survivor, and a good friend of us here at Another View. And thank you so much, Frida, for everything that you do also to help us. We appreciate you.
Frida.
Okay, let's go to Jack in Norfolk. Hi, Jack. You're on the air.
Yes, I'm calling in reference to referrals. I had the major surgery about a year ago. And before I had the surgery, I really had no problems other than just maybe a couple of polyps that showed up. But at the same time, my doctor said that I would need the surgery because it would be a good idea to have the surgery because you never know what's on the other side. But since the surgery, I've had several bowel blockers. I've been in the hospital. It's been about a year now. And I've been in the hospital 3 times behind the surgery. And now I'm saying to myself, they took 11 inches of my colon out, plus some part of my small intestines, and there was nothing there. They found nothing. Plus, at the same time, I have no history of cancer anywhere in my family. And at the same time, a couple of other doctors I've gone said that I should have had the doctor should have said, if you have any doubts. And I questioned the doctor before he did it. I said, I feel great. I feel like I have no problem. But at the same time, he kept telling me, but you don't ever know what's on the other side of the colon. So I guess I went for it. but at the same time, I'm paying the price for it now. So your panel might want to respond to that.
Jack, okay, thank you so much for the call. We can't really respond to that, not knowing the circumstances behind it. But the bottom line is, in terms of if you have questions or you want to get a second opinion, then you should get that second opinion.
Well, I think the
Keith.
thing I would say to that is, I couldn't quote on the actual incident itself just because we don't know all the firm details. And the one thing I always try to do when I do second opinions is I don't ever make any judgments on what somebody else says or does because you just don't know all the details. But I do know that if there's any questionable areas, I know a lot of times they will, kind of more prophylactically or empirically will resect because of certain things you may not always see or know, and there are certain areas you can't get to, I think, in the screening process. So if there's a question about it, that may come up. So the thing is, on the flip side of that, if you didn't have it done and then something did show up, then we would be looking at a worse scenario. But again, I think the way you always just get the data and ask questions. And, that's the best thing I could ever advise anybody.
Okay. Joanne joins us from Franktown. Joanne, where is Franktown?
Franktown is on the Eastern Shore.
Ah, okay. I always learn something new. Thank you for calling.
But if I say Eastern Shore, they want the name of a town. So I said, okay, I'll give you where I get my mail.
Well, I love that. I love learning the names of the towns there. So thank you so much for your call. What's your question?
Well, I wanted your experts to comment. There was earlier in the broadcast, there was they talked about the bacteriological biome, and I wanted them to take it from the positive and the negative because, since we live in such an age of high antibiotic consumption, unfortunately, what people don't realize is it knocks out the good and the bad and the indifferent, and the gut pays the price for it. So I just wanted them to comment on the good bacteria because everybody always thinks that bacteria are automatically negative, but there are good bacteria that keep us healthy, and it's a constant balance back and forth between the good, bad, and the indifferent. So
okay, let's let Dr. Cross answer that. Thank you so much for the call, Joanne.
Yeah, so I'd certainly echo that. There is a broad diversity of the type of bacteria that exists in our colon, and there are certainly some that have more virulent or can cause infections. We all have heard about Clostridium difficile these days, which are on the rise. E. coli bacteria that get certainly associated with outbreaks of foodborne illnesses. But there are more than a dozen different subtypes of bacteria, some Bacteroides species, Fusobacterium, but there's different species of bacteria in the colon that are very favorable for us. And right now the problem is we really just don't understand the makeup and the exact constituents that would consider a truly healthy microbiome, and how much that varies from individual to individual or people in different parts of the world. So there's not enough information to fully comment on how you would develop a more favorable microbiome right now, but that is an active area of research that I think we'll learn more over the next 5 years.
Okay. I think we have time for one more call. Gwen joins us from Hampton. Hi, Gwen. You're on the air.
Thank you. I have a quick question. At what age do colonoscopies end, the need to have those done?
That's an excellent question, Gwen. Thanks for the call.
Excellent question. So I think if you have someone who has a personal history of colon polyps, or certainly a personal history of colon cancer, that person will probably continue to get screened until there's an estimate they are unlikely to survive more than another 10 years, 5 to 10 years. But it's really a discussion that the individual would have with their physician. For most people, for the average risk person, though, I think there's not much data that suggests that screening past the age of 75 to 80 provides any major benefit, but that's also making the assumption that the average person is going to survive to maybe 77 to 78, and again, for an individual, that may be just unlikely. You have somebody who's very healthy, very active, in their mid-70s, continuing to screen them is certainly a reasonable thing to do. Mm-hmm. But it's a case-by-case basis. But as a party line, I would say 75 to 80 ends up being for the average risk person, probably the upper limit when screening is appropriate to stop.
And so, in the last 2 minutes that we have, if you are 50 years old and you have no symptoms and you feel fine, should you just ignore it?
You should get a colonoscopy because a whole lot easier to have a small polyp taken out than have to come see a guy like me.
Okay,
and I wanted to say a couple of the testimonies from our church. I think it's important that we keep this information in the forefront. We have to keep pounding health education in our congregations because we know in the church it's just a prime place to get information out to the African American community. And a couple of testimonies, we have someone who comes to regular exercise and she went to the doctor and her levels were down in terms of, illness that she has. Someone else had a colonoscopy in the past but had not had one in 13 years. And because we kept pounding the information, he went, and there was something found, but praise God, it was okay. It was benign. So I'm on a mission. I know Dr. Newby and Pastor Gloria. We want to save lives, through the gospel, but as well as, like Dr. Newby said, education. Common sense
is the key. We are out of time, you all, but this has been such a fabulous conversation. And I know you all want to encourage other churches if they just want to get started. It doesn't necessarily mean a grant has to happen, but just get started and spread the information, correct? Very quickly.
Very quickly. And I, as the community ambassador for the American Cancer Society, has had opportunities to go to other churches to speak about colon cancer and breast
Where's
cancer.
the phone number they can reach you?
757-618-2952.
And for screening, do we have time to give a number? Screening information for low-cost screening, 493-7969. That's Kim Robinson with the American Cancer Society.
Okay, we are out of time, but you can call the Another View office, and we'll also have those numbers for you. And we will be right back.
Hi, this is Essie Patha-Merkerson from Law and Order. You are listening to Another View at 89.5 WHRV.
Oh, Victor, our audio guy, always makes me smile because he knows that's my favorite show on the planet. But anyway, the Hampton Roads area is home to many talented young musicians, and Norfolk Mosaic Steel Orchestra is just one example. The group began 8 years ago and has been captivating audiences ever since. Our Lisa Godley recently spoke to the orchestra's founder and some of his students about their impact on this community and plans for the future.
Community and diversity, two values the Mosaic Steel Orchestra strives for, and the group's founder, Dr. Anthony Haley, says they are key reasons why the group is a success.
It's all about diversity, and I know that's the key to my success with Mosaic Steel Orchestra. It's because I keep our ensembles diverse. We start while the kids are young, and we instill teamwork, we instill discipline, self-confidence, and professionalism, and a performance etiquette, so they know how to carry themselves when they're in front of people. And so on a whole, if you ask me what Mosaic Steel Orchestra does for the community, I think we're making better citizens.
Two of the students from the ensemble, Taylor Simon and Precious Jernigan, describe what it's like being a part of the group. Simon has been a member for 5 years.
I'm an all-around percussionist, so I do like marching band, I do regular school symphonic band. I'm in a local wind symphony outside of this. I like it all, honestly. I mean, this is awesome. Like, steel drums have gotten me to places I wouldn't have imagined like this. So this is kind of crazy, like music bringing me this far.
He's looking forward to performing in Trinidad for an upcoming international competition.
You have bands from Europe, native bands from Trinidad, Asia, South America, North America, Canada. It's like crazy. We are going against the best, the creators of this instrument.
Precious Jernigan has been a member for 2 years. She joined Mosaic Steel after taking steel drum classes at the Attucks Theater.
It just takes a lot of stress off you if you're going through something, and I just come in and just be very excited to play and to spend time with them. It keeps my confidence up and builds my self-esteem up, because before I had very low self-esteem, and when I got in Mosaic, it just gave me confidence.
She's looking forward to traveling to Trinidad for many reasons.
Meeting different cultures of people and exploring, getting to see more of the world and finding myself.
Dr. Haley is taking about 45 members to the competition. For some, it's their first time out of the country, but it's certainly not the first time traveling with the orchestra.
We've traveled outside the Hampton Roads area extensively to the state of West Virginia. We've performed at Miami University in Ohio, in Oxford, Ohio. We've performed in a similar competition that we're going to compete in this year in Trinidad. We performed in New York City.
He says inspiring people to make a better tomorrow is his mission.
The kids get out and perform a lot, and that's one of the things I really like to get them exposed to, a variety of environments. We had a performance at NASA Langley Research Center. It was very educational. We had a tour. I learned a lot. We were blown away. I hope we inspired some future engineers.
And the students aren't the only ones learning. He makes sure his program is open to everyone.
We have classes for seniors. We have regular adult classes. We have youth classes, after-school programs. We have after-school programs here in Norfolk, in Portsmouth, and in Suffolk. We're working on the Newport News in the East End. I'm hoping that comes through well, because I'm attracted to those underserved neighborhoods. Through this activity, Steel Pan, it causes them to be more helpful, more productive in society as a whole. These programs have a way of benefiting kids in a manner to which they want to turn around and give benefit.
For Another View, I'm Lisa Godley.
And for additional information on the Mosaic Steel Orchestra, you can visit mosaicsteelorchestra.org. Today's story on the orchestra was produced by our Another View interns, Autumn Bracey and Jessica Jane, and we are very proud of them. And that's it for today's edition of Another View. Our health is so important, so please download our podcast and share it with someone you love. You can find it at anotherviewradio.org, where you can also sign up for our eView newsletter, a once-a-week reminder of upcoming programs. The podcast will be available after 3 o'clock today. Next week, we talk with the leadership of Norfolk State University about efforts to remove the probation status with SACS and initiatives designed to ensure a brighter future for the HBCU. Our theme music was composed and performed by Jay Sinnott. Lisa Godley is our show producer. Victor Bowen is our audio engineer. And Jessica Jane answered our phones. I'm Barbara Ham Lee. Make it a wonderful weekend, everyone. And let's get together again next Friday at noon for Another View.